In this presentation, we are going to talk about some acquired heart diseases that are common in the pediatric population. So those things are things like dyslipidemia and Kawasaki disease, rheumatic heart disease, but keep in mind kids also get things like cardiomyopathy and myocarditis. But we will be just looking at a few of those diseases specific to children. Our focus for today pertaining to acquired heart diseases is going to be infective endocarditis, Kawasaki disease, rheumatic fever, and hyperlipidemia. When discussing infective endocarditis, keep in mind that this is an infection of the endocardial surface of the heart. Generally, these children have a history of congestive heart disease, Kawasaki disease, rheumatic fever, or a prosthetic heart valve, because these are all more susceptible to infection, right? So some symptoms are fever, fatigue, joint and muscle aches, loss of appetite, weight loss, diaphoresis, a new heart murmur, and those signs and symptoms of congestive heart failure. Treatment for endocarditis is IV antibiotics for 4 to 6 weeks. Some preventative measures are prophylactic antibiotics, and that can be seen with any dental care or invasive and respiratory procedures, especially for those children that are high risk. So with this, keep in mind the endocardium is injured by a high velocity blood flow or a turbulent blood flow across a septal defect by a position of central venous catheters. This can also be caused by implanted vascular grafts, patches, prosthetic valves used during cardiac surgery can also be some sites of infection. You just have a visual of what endocarditis looks like. To talk quite a bit about Kawasaki disease. What is this? It's an acute febrile systemic vascular inflammatory disorder that affects small and mid-sized arteries, including the coronary arteries. There is generalized vasculitis. The peak incidence is generally seen between 6 months to 2 years of age, and the etiology is often unknown. It's thought to be an infectious trigger in genetically predisposed children. You also have a little website here to explore more. How is Kawasaki disease diagnosed? Generally, there's a fever persisting at least 5 days, plus the presence of 4 of the following symptoms: a non-purulent conjunctivitis, changes to the lips, oral cavity, strawberry tongue is very, very pertinent, redness and cracking of the lips, and erythema of the oral mucosa. You have palms that are generally red and edematous, and then it can also be on the soles, so the palms and the soles, and then after that resolves, you see some discrimination, so that peeling of the skin on the palms and the soles of the feet. So there is a characteristic rash on the trunk and cervical lymphadenopathy. So those are the things that you are going to see. You'll get some pictures here in a little bit to hopefully help you to focus on this, because those symptoms are very important for you as the nurse to recognize. So there are 3 different stages with Kawasaki disease. So you have the acute stage lasting 1 to 2 weeks. In that stage, you'll see that high fever, irritability, conjunctivitis with no drainage, bright red chapped lips, strawberry tongue, red oral mucosa and membranes, swelling of the hands and feet with red palms and soles, and a non-blistering rash. You'll also see those enlarged lymph nodes. Then you have the subacute stage. this is about lasts like 2 or more weeks. You see that resolution of the fever and some of the other clinical symptoms subside. However, you've got that cracking of lips, peeling of skin around the nails, on the palms and the soles, joint pain, cardiac disease, and thrombocytosis. And then you have the convalescent stage. So this is at about 6 to 8 weeks. So you see that deep transverse grooves or bow lines that may appear across the nails and the hands, on the hands and the feet. A visual of the Kawasaki disease rash on day 4 of the illness. This is in a 7-month-old boy. Now you have a child with Kawasaki disease. Red eyes will be noted, dry, cracked lips, and a red tongue. With this little girl, you see edema and erythema on day 6 of the illness. This is in a 1.5-year-old little girl who is experiencing Kawasaki disease. Here you see the peeling of the fingertips and those bow lines across the nails in the last stage of Kawasaki disease. To recap on Kawasaki disease, the type of disease that this is primarily affects young children, and it's believed to be caused by a non-contagious infection. Some symptoms include that, pink, red eyes, oral mucosal change, enlarged lymph nodes, the patchy rash, and the peeling skin. You see this inflammation of the heart muscle here and some coronary artery aneurysms that can occur. Some diagnostic tests with Kawasaki disease. You'll see an elevated white blood cell count, an elevated ESR, elevated platelets, and on those echocardiograms, those are used to identify specific vascular changes in the heart and those coronary arteries. How do we treat Kawasaki disease? So they're going to get intravenous immune globulin, high doses of aspirin while in their hospital. That's a little different, but that's the treatment for this. A low dose of aspirin upon discharge, and then we're going to be monitoring for cardiac disease for several months afterwards, because that risk of coronary aneurysms or myocardial infarctions are higher in these children. As far as nursing management, and what you are going to focus on as the nurse is to administer that aspirin and those IVIGs, and then monitoring for side effects. You want to promote comfort, so you've got those pain medications, keeping the skin cool and dry, lubricating the lips, the cool compresses for fever, and small frequent meals and liquids that are not too hot or too cold. Remember, they've got that dry, peeling skin, their oral mucosa, their tongue's irritated, their eyes are irritated, they've got that fever, so promoting that comfort is very important. Also doing passive range of motion exercises, providing rest periods, and providing discharge teaching. Okay, let's look at this question. You have a child that has Kawasaki disease. They're going to receive the IV immunoglobulin on day 7 of the illness. And the parent asks the nurse, I'm so scared, will my child be cured after the medicine? So what's appropriate? What is an appropriate response by the nurse? So you don't really want to say D, that's not really appropriate. And then C, you don't want to choose that one because you don't want them to think that you don't have any knowledge. And then B, you don't want to give them any false hope by saying, I'm sure your child will be fine. A would be the best response, because saying, I cannot promise, but children have been shown to have the best results from the medicine when it's given before the 10th day of the illness. Now let's talk about rheumatic fever. We do talk about this quite a bit in this course. So first and foremost, rheumatic fever is an inflammatory immune disease that affects the connective tissues of the heart, the joints, the skin, blood vessels, and central nervous system. It may lead to chronic valvular stenosis or regurgitation. Rheumatic fever manifests during 2 to 6 weeks after an untreated group A beta hemolytic streptococcal infection of the upper respiratory tract. So what is that? That's strep throat. Remember we talked about strep throat a while back. Um, so or they could have like impetigo, because you know that can be caused by the streptococcal virus, scarlet fever, or any other illness, again, caused by streptococcal pathogens. To diagnose rheumatic heart fever, it is diagnosed if there are two or more major manifestations, or one major manifestation, or two or more minor manifestations. And those need to be present with the evidence of that recent group A strep infection. So that's like recent scarlet fever, positive throat culture, elevated antistrepsin titer, or other strep antibodies. So major manifestations are carditis, polyarthritis, urethemia, cholera, subcutaneous nodules, and then minor manifestations are fever, arthralgias, elevated ESR, positive C reactive creatinine or reactive protein, or a prolonged PR interval on an EKG. Treatment for rheumatic fever involves antibiotics. So you're going to have penicillin V for 10 days, anti-inflammatories such as aspirin and corticosteroids to prevent any cardiac damage and to treat that arthritis, and then bed rest. When looking at nursing management for rheumatic fever, we are going to focus on prevention. So, you want to test and treat those with possible strep infections, right? Place on droplet precautions for the first 24 hours of antibiotic therapy. Control that joint pain with hot and cold applications. Administer antibiotics and teach the parent to complete that full dose regimen. Administer salicylates and anti-inflammatory agents, and then arrange for rest periods and provide quiet activities. You also want to monitor for signs of endocarditis. Those signs are tachycardia, new murmur, chest pain, and EKG changes. Recommended screening for dyslipidemia should happen when a child is between 9 and 11 years of age and 17 to 21 years of age. So you just want to do it once during those time periods. Keep in mind that they may draw a non-fasting for that screening. And then, if there is like a family history as far as like risk factors, it may be done with children between the ages of 2 to 11 and 12 to 16. So maybe just a little earlier if they have that family history. Especially if it's cardiac disease, if they have a parent that has a total cholesterol above 240 or obesity. And then, oftentimes they'll do a fasted lipping panel 2 different times and then average those results. They have a chart of normal cholesterol levels and then higher risk levels. Here we have the last slide in our discussion today about acquired heart disease. So when we talk about dyslipidemia, what are some interventions? What are some things that we can do for these patients? We want to promote dietary and physical activity, so at least an hour a day. High fiber, 5 servings of fruits and vegetables, whole grains, limiting those sugar and sweetened beverages, encouraging water intake, unflavored fat-free milk, and avoiding trans fat. So keep in mind, this is all directed towards pediatric patients. And, if you think about what their diets look like, this may be difficult. So lots and lots of education and lots of encouragement is needed as well, not only for the child, but the caregivers. So that concludes our presentation on acquired heart disease.